These new drugs are new. If this had happened to me 10 years ago, I would be gone. And the slope of advancement in cancer research is almost vertical. It's just amazing what's happening right now.
Behind every kidney cancer diagnosis is a person navigating difficult decisions about treatment and care. Today, we're diving into the therapies available, how they've evolved, and what that means for real patients. Hello, all, and welcome back to another episode of Hot Topics in Kidney Health. I'm your host, Marlena Chesner, NKF's Digital Content Development Manager. Today, we're discussing kidney care treatment, specifically how to navigate its side effects and how to tell the difference between side effects and warning signs. Before we begin, I'd like to thank Exelixis for supporting today's episode. I'm joined by Dr. Rimda Wanchu, a nephrologist or kidney doctor, Dr. Julia Stevens, a clinical pharmacy specialist in oncology, and Andrew Allers, a person with a history living with kidney cancer, who brings a lot of personal experience to the table today. So thank you all so much for joining me. I'd love if we could start with some introductions. Dr. Wanchu, would you like to tell us a bit about yourself, where you work, and what you do in the kidney field?
I'm an adult nephrologist. I work at Northwell Health in New York. As I'm a nephrologist, I take care of patients with kidney disease, primarily adults, and it involves all kinds of kidney disease, chronic kidney disease, glomerulonephritis, patients on dialysis and kidney transplant. But I do have a special interest in the field of onconephrology, which is an intersection of nephrology and cancer. So patients who have, normal kidneys when they start chemotherapy and then go on to develop chronic kidney disease and issues with, electrolytes post-treatment, I specialize in that also. So I'm thanking the NKF for including me in this podcast. I'm really excited to be here.
And we're so lucky to have you and your expertise here. Dr. Stevens, would you like to do the same, please?
Of course. Well, it's an honor to be here. I am Julia Stevens. I am an oncology clinical pharmacist, and I subspecialized in GU and melanoma. So many of my patients are living with kidney cancer. In my clinical practice, I work at Beth Israel Deaconess Medical Center, and I collaborate with the medical oncology team to care for patients who are on active treatment. I have the most care for patients who are on oral therapies of various forms, but I also provide support for those who are getting immune therapy and intravenous therapies as well. I also am a member of the Kidney Cancer Association Clinical Advisory Board, so get a little bit different view on kidney cancer from that perspective also. So thanks for having me.
Oh, wonderful. Thank you so much for being here. And Andrew, would you please share a brief overview of your kidney cancer story with us?
Hi, thanks for having me. My name is Andrew Allers. I have been a kidney cancer patient for a little over 10 years. I just had my 10-year celebration dinner last October. I was diagnosed incidentally in 2015 as a result of a soccer injury. Kidney was removed. We thought everything was going to be fine. And then in 2019, it came back stage 4. I find it hard sometimes to tell the story chronologically because so many things happen on such an erratic scale that I'll just sort of give a summary. I've had tumors in my kidney, my brain, my lungs, lymph nodes, rib, and hip. I've had radiation on my rib and hip, 7 sessions. I've had 7 sessions of brain radiation for brain tumors. I've had multiple surgeries, a nephrectomy, craniotomy, lung resection, 3 joint replacements, which, may or may not be sort of aggravated by my autoimmune reactions to the treatments. I've been on immunotherapy for a little over 7 years, and I've been on an oral medication that tries to stop the tumors from recruiting blood vessels for a little over 3 years as well. And in spite of all that, as terrible as it sounds, I have a great life. I'm active, go to the gym regularly, play sports, hang out with my dogs, and I'm very, very happy to just be here.
Oh, thank you so much for being here. I think your insight is going to be so incredibly helpful to the patients who are listening today.
It makes me so happy to hear you enjoying life beyond our clinic, beyond treatment.
Thank you all so much for being here. So let's kick this discussion off. Dr. Wanchu, there have been many advancements in kidney cancer treatment over the past decade. How is it being treated today? And can you elaborate a bit on the differences between the types of therapies?
So, there's been significant advancement in the treatment of kidney cancer. Historically, I believe the treatment options were limited, but we've really come a long way. And that's primarily because of targeted therapy and immunotherapy. A lot of patients who have widespread cancer can, get immunotherapy or a combination of targeted and immunotherapy, which has shown in several studies to really improve the overall survival of these people. So patients are living longer. And as Andrew's saying, leading a very fulfilling life. The main difference between the immunotherapy and the targeted therapy is that immunotherapy essentially works on your own body's immune system to stimulate it, which in turn fights the cancer. So it's not as if you're getting a pill which is sort of fighting the cancer. It's actually your own immune system that gets revved up and fights. So because your immune system is active, that in turn can lead to a host of other immune related adverse events. So that's the most common sort of adverse effect with immunotherapy. The targeted therapy is sort of therapy which is more targeted towards specific molecules, proteins, genetic mutations, which which are all sort of involved in the progression or growth of the tumor. So they are sort of more specific in the cells in which they act, which is sort of very different from the traditional chemotherapy, which sort of attacks all cells, good cells, bad cells, all together. So that's really the key difference now in the management.
Exciting way to hear it that, now have these medicines that can actually target these things. But I'm curious, Dr. Stevens, what are some of the side effects people can expect from both these different types of medications? And does having any side effects mean the treatment isn't working or if it's harmful?
That's a great question. Well, as Dr. Wanshu alluded to, our immune therapies usually have side effects that come from overstimulation of the immune system or the immune system going and attacking something else in your body. So, the most common targets for that would be the GI tract, which could cause diarrhea, the skin, which would cause rashes, and thyroid, which would cause low thyroid levels typically. That being said, immune therapy can cause your body to attack other organs too. So other things like muscles, some and very rarely like brain or heart could be affected, although certainly those are not the most common ones. Targeted therapy has pretty different side effects. So I think of this both as our VEGF TKIs, so things like cabozantinib, lenvatinib, and then also we have our HIF-2 targeted therapy, which would be belzutifan. So our VEGF TKIs can classically cause higher blood pressure. They can cause some diarrhea. And then there's some more rare side effects such as peeling or tenderness of the hands and feet, mouth sores, changes in appetite or energy. Belzutifan, on the other hand, classically causes things like anemia and hypoxia. It's really important that patients are really aware of what kind of treatment they're receiving and what the most common side effects are. And then we also talk to patients a lot about exactly when to call the team and what can be managed at home versus what is something that needs to be something that just comes to see us or maybe goes to emergency room as more acute. Generally speaking, there have been a lot of people asking this question of like, does side effects and effectiveness ever align? And really, that's not typically the case. Patients can have side effects, but no cancer control. Patients can have cancer control and no side effects.
And now I'm curious, Andrew, since we've been talking about side effects and medication, if you could share a little bit about your experience with them and if you felt well informed or not.
Sure, a little triggering listen to Julia talk about all those because many of them I've had. I take cabozantinib targeted therapy, and I have had GI issues. I think sort of everybody has that. I have been spared the problem with the bottom of the feet. I don't know if I'm fatigued because I'm 60 years old. I'm active, so I'm always tired. I don't really know. I talk to a lot of other patients, and if you read the side effects and you read about them, it's terrifying. And I've had people come to me and they know that I've been on this for a while. So what should I look out for? And my advice is always just wait, see what happens. They're not all going to happen to you. Whatever happens to you, you deal with that as it comes. But it's pretty intimidating looking at the side effects. I have been on immunotherapy for a little over 7 years, and I think that constitutes a pretty durable response. I think the median response is something like 2 years. So I started with a 2-drug combo, nivolumab and ipilimumab, in July of 2019. I believe that was approved as a first-line treatment in like April of 2018. So it was only a year later that I was doing it. And I had a previously unspecified autoimmune disease. And I think most of the clinical trials and most of the research into these things were on people with healthy immune systems. And that, to me, is a really interesting sort of tweak on it. Now that it's being released into the sort of the general population, all the people with autoimmune issues, it's different. Nobody can really tell me what's going to happen with me and my disease. My oncologist says, we're kind of learning from you at this point. So I've had a pretty violent autoimmune reaction to that Ipi-Nivo combo after 2 sessions, and I had to stop. And, it took about 6 months of sort of figuring. My rheumatologist, who most of her patients were mice, I was one of her few human patients, I think, she theorized that maybe IVIG, intravenous immunoglobulin, would sort of help me modulate my immune system so that it could tolerate the immunotherapy. I've been on that for 6.5 years now, and back on the Nivo, and it all seems to be working. Below the neck, I've been not tumor-free, stable for about 7 years. That's another thing I think that's sort of difficult to get your head around with kidney cancer is these tend not to cure you. They tend to sort of chronically manage your condition. And it's a little bit of an emotional toil dealing with that. You keep wanting to sort of be cured, and it's not there. Every time I go in for a scan, the tumors are there. They just don't move, which is great, but it's a little weird thinking that they're still there. At this point, I'm probably talking too much. I'm not even sure I'm still answering the same question.
No, I think that was all really, really relevant information. I think, is there anything that you wish you had known sooner about, these treatments that you could kind of share with others? I know you said everyone reacts differently, but I think that bit about you sharing, it doesn't always go away is maybe one of those things.
Yeah, I feel like I was very well informed about what could happen. I was told about my thyroid, that could sort of kind of stop working. I was told about the possibility of diabetes being caused by the immunotherapy. I think I was fairly well informed about the side effects. I studied math in school, so I like numbers, and I had to sort of push my oncologist to give me likelihoods in numbers rather than likely or not very likely. So I make it a habit of finding doctors that will talk to me and that will actually have a conversation with me. And I've had no trouble doing that, but there have been some along the way that haven't worked for me because I didn't feel like we had that. I like to find a doctor that says something that makes sense to me. I don't necessarily understand it. I can convince myself that I do sometimes, but I want it to make sense. And I want to be able to sort of ask the doctor, so in my layman's terms, this is what I think you're saying, and then have that conversation back. So I think I was very well informed about that. Oh, I was going to respond to something that Julia had said. Something Julia had said earlier about, do the side effects indicate efficacy or not? I think about this a lot because I had very violent side effects, autoimmune side effects to the Ipi-Nivo combo, and I've had a very durable response. So when I look around for sort of studies about people like that, there is some sort of thread of conjecture that a violent autoimmune reaction, it's not the reaction that sort of means it's working. It's a sense that your immune system is responding to something. I don't know what the science actually says. I don't know if there have actually been definitive studies, but it made me a lot happier it made me think about my reaction a lot less painfully.
I actually have something to say to that. Not necessarily for immunotherapy, but for kidney cancer and patients who are on drugs like cabozantinib, the VEGF TKIs. One of the most common adverse effect is high blood pressure. And studies have indicated that patients who actually develop hypertension tend to do better on the drug versus those that don't. So there is some literature on specifically hypertension, VEGF inhibitors, and kidney cancer.
That is fascinating and also very confusing, I feel like, for people who are trying to live that experience. But um, definitely does hopefully give everyone a different way to look at these symptoms. And also why it's so important to talk to your doctors and find people that you can speak with about these things. So, Dr. Stevens, when a patient is reporting symptoms or side effects, how do you use those to adjust doses or modify? What are the next steps?
It's a great question. I would say the approach to side effects is really an art. Certainly, we draw from science also, and there are some studies out there that are really helpful, but it's very helpful to be at a center that does this often because how to respond is something you only get better with experience. So, for some side effects, such as the autoimmune side effects, we think about starting steroids if it's something that is a critical organ. We're talking like, liver, lungs, heart. We need to be starting steroids as soon as possible because that is something that will potentially save that patient's life. If it's something that's like maybe less critical, less severe, like maybe you just have a rash, um, we can start topical steroids, or if it's a widespread rash, we're starting maybe systemic steroids. But it's really, we think about grading it. So graded is one way to capture the severity. And there's some standardized grading criteria for all of these side effects. For things like targeted therapy, we also think about grade and we think about how much the side effect is impacting a patient's daily life and function. So for something like blood pressure, certainly we can be starting blood pressure medications, adding, adjusting. We might need to be holding targeted therapy for a certain time while we do that to make sure that we're safely managing the patient. For something like diarrhea that's just from targeted therapy, not from immune therapy, we're really starting antidiarrheal medications and making sure the patient is hydrated and managing that okay. Certainly, holds and dose reductions can be helpful here too. Really, for targeted therapy, a hold is something that's very important, not just to prove that something is drug related, but also because that will help you get better faster. And then we can maybe try a lower dose after holding. So it also, just to talk briefly about belzutifan and HIF2 inhibition, the classic side effect there is anemia, which is directly due to belzutifan causing low epoetin levels in your body. And so one important thing to do there is to give you back epoetin. There are some synthetic forms of that we can give back, darbepoetin, epoetin. So one barrier I run into with my patients is just them being hesitant to use drugs to treat side effects of their kidney cancer treatment. There's often a perception of, I'm taking so many medications, what other side effects am I going to get from these other drugs? And so here I would just really want to emphasize that we can use supportive drugs to help keep people on what we would call their maximum tolerated dose. And these drugs we're using supportively are often very safe and very effective at even higher doses than we are using for most patients. So it's all trying to keep people on treatment in a manageable way long term. And supportive drugs are really quite safe. But that's a common barrier I see with my patients. So I would say that is just a little flavor of what this might look like across the different side effects across these very different drugs. But generally speaking, we're thinking about pausing the treatment maybe temporarily. We're thinking about maybe trying a dose reduction for targeted therapy. But it's critical that patients are in touch with their team, that they build trust with their team. I think all my patients gain a better understanding over time about like what is critical, what is something that I can do by myself at home, or what's something that I need to either urgently call in or present to the emergency room. That's not always intuitive, but I think over time everyone gets to understand their body better and these treatments better.
And I can imagine tracking symptoms could be a very helpful way of learning about, your body and making more informed decisions moving forward. So I'm curious, Dr. Wanshu, what are some ways that patients can track these effects? And what details are you looking for patients to bring to you in regards to what they're experiencing?
So I'll obviously be focused more on the kidney related adverse effects. But let's say a patient starts a VEGF TKI, which is known to cause high blood pressure. It is known to actually sometimes even lead to protein in the urine. So what I'll tell my patients is that keep a log. You could keep a notebook or you could, keep it on your phone. But I need you to track your blood pressure on a daily basis. You don't have to, not if not daily, then at least 3-4 days a week. And it's important sometime with the symptoms to see what the trend is. You could have something for a day or two and then it gets better. That's obviously not that concerning. So I need the patients to log everything and then also explain if there's something that they feel makes the symptom worse. Is it, what is it that they're doing that makes it? Is it eating something that causes the diarrhea to get worse? Or is it, where they've gone out to eat and the blood pressure suddenly shoots up? So if they could note down sort of factors that make it worse, factors that make it better, when did it start? I think all those things are very helpful, when they bring it back to me and I can actually look at that and sort of decide what the next step is.
Yeah, I think all that makes a lot of sense. I'm curious, Andrew, how have you tracked your symptoms, and do you have any advice for other patients who are maybe trying to do better at it?
So after telling you I studied math, now I'm going to tell you I had absolutely no systematic way of tracking symptoms. I was very sort of, as they happened, I talked to my doctors. I was very communicative with my doctors. I make sure that that's the case. The bad reactions I've had, there's one in particular that sort of required a bit of management. The rest of them have all been just kind of in your face and obvious. The autoimmune reaction to the immunotherapy, it was just obvious. I could barely walk. I had a full body rash. There was swelling in my lungs. So that was easy. The Cabometyx, the TKI, VEGF sort of inhibitor, the GI stuff, it's just pretty straightforward what's happening. One difficulty, I think, for patients is if you look at the side effects for nivolumab and the side effects for cabozantinib, there's a lot of overlap. So what does that mean? And nobody knows, really. You can sort of guess, and you can talk about the way they manifest, but I've gone through the dose adjustment with cabozantinib, and that seems to work. I read a lot about people sort of who struggle with the dose and with the management of that. So I just do it by talking a lot to my doctor. I had one, I don't know if you want me to share sort of the most sort of difficult side effect management that I've had. I had, like I said, radiation on my hip and rib in 2019. Fast forward to 2023, I had a knee replacement. My knees kind of just went south. I had my left knee replaced, and the atrophy from pre-surgery just wasn't coming back. And I would talk to my physical therapist, my personal trainer, my orthopedic surgeon, my GP, my oncologist, everybody I talked to, the number of people I talked to, and I said, "Are you worried about this?" And nobody was worried about it. It got to the point where my foot felt like there was something in my shoe all the time. So I thought maybe I have a neuroma. Go to a podiatrist. Well, it's probably just recovering nerves from the knee replacement. So this went on for 2 years probably, where it just didn't get better. And I was going to the gym a lot, and nobody else seemed to be worried about it, but I wasn't satisfied. I just kept pushing. And finally I talked to a neuro-oncologist, and she diagnosed me with, it's a real mouthful, radiation-induced lumbosacral plexopathy. So there's a nerve that comes off the spinal column through the hip socket that fans out to support the rest of the leg. And the radiation on my lesion on my hip was right there. So that was damaged. And interestingly, the median time for that to manifest is like 5 to 7 years. So it was exactly the right time. And so, the downside is there's no solution. There's no cure. My leg is permanently atrophied, and my foot feels like I've been skiing with a really bad ski boot all the time. But I have a clarity on what it is. I'm no longer worried about this developing in my right leg and my arms and taking over my whole body. I know what I can do to sort of minimize the effects, but that was the most sort of, I'll say, interesting, frustrating one. And I think one of the things to talk about there is people didn't used to live 6 years after radiation. So this isn't a super well studied topic. At least that's my understanding. And so on one side, I'm super happy. On the other side, I'd really like to be able to run again. But I think that one, I just wouldn't give up. And I can't tell you how many times I talked to people and said, I'm worried about this. Are you worried about this? What's going on? Until I finally got an answer. In retrospect, maybe I could have pushed even harder, but that was probably the most difficult one that I had to sort of help diagnose.
Andrew, thanks for bringing up the overlapping toxicities too. Now that almost everyone's getting some combo frontline, that's a huge area of controversy and definitely something we're seeing in the clinic. I would say this is another art. So sometimes things like onset time can help. If you just started Cabo Nevo and within a week you have diarrhea, that's probably the Cabo, since immune toxicities are typically delayed. If it's a side effect that doesn't get better when you stop your TKI, that might point to the immune therapy. But you're right, there's definitely no cut and dried answers, and it takes a lot of detail, especially detail from the patient about a lot of those other things. Speaking about diarrhea specifically, if you have like blood in your stool or a lot of abdominal cramping, that might be a sign that is more related to the immune therapy. So really the patient is a key collaborator here in helping us get to the bottom of these things.
Yeah, and it's also sort of reinforces what I think is important about having the relationship with your doctor. Because when you're talking about pausing or dose control, it's scary. You want to pause this for 6 months. Well, what's going to happen in that 6 months? Some tumors grow really fast, some don't. So it's really important to me to have that back and forth. And also to me, this might sound a little odd, it's comforting to me to see the uncertainty in my doctors, because then I know that they're thinking, they're trying to help. They're not just saying something that they learned, or they're not thinking they know everything. That to me is like vital, having that kind of relationship where you can my doctor often says, I don't know. But then, well, let's find out.
I can imagine that the honesty and knowing that you can trust them to be upfront with you would be very comforting in these situations. So that, I think, makes a lot of sense. And as we're talking about these side effects and pauses, to either of our doctors, why is it so important to not stop treatment on your own, even if the side effects are feeling very overwhelming?
I think because, like Andrew just mentioned, first of all, if you stop a treatment and your treating physician doesn't know, that puts you at risk for progression of the cancer itself. So I think a lot of times patients will stop something without consulting, and they don't understand that a lot of these side effects are manageable, right? If you have diarrhea, you're going in 3 times a day. There are medications that you can get that can help control the diarrhea. So I think it's important to sort of communicate with your care team, only because you'll be surprised there are things that can be easily managed without having to stop the drug. So I think that's why it's key to let the physician know. Obviously, if something is very severe, persistent, out of control, that also is something that you need to communicate, because sitting at home is not going to manage it. Maybe you're getting dehydrated. You need to come in either to the cancer center or to the hospital to get hydration. So it's, I think the way of looking at something more objectively is sort of lost as a person who's suffering. But I think there's more clarity when you communicate with the other people, because a lot of these things can be managed. And, we can continue the treatment and manage the toxicity most of the times. Yes, there are a subset where it is important to hold therapy, and that's different. But that's why it's easy, most helpful to communicate.
Yeah, just to add to what Dr. Wamtu said, there are also side effects where stopping is not enough. And, you might need to have high dose steroids, or you might need an admission or fluids that you're not going to be able to do that on your own. I tell my patients it's a stop and call. So certainly if you feel like you need to stop the drug, you need to be your own advocate here, but stop and call us. Tell us what's happening and we can try to help you, or at least can follow you more closely to make sure things are getting better at home.
I think, sort of from a patient perspective, I can't imagine why you would want to stop and not say something to the doctor unless you don't have the right relationship with your doctor. And that sort of gets back to my point. Like, if you feel like you can't tell your doctor because they're not listening, find a new doctor. That may seem a little bit presumptuous, but like, you need to be able to talk to people. The only solution is talking about what's going on, because nobody else is going to know unless you explain it to them. And some things are very hard to explain.
And I think that's really key, because I think cancer treatment, it's a long journey. It's not a 10-day problem. It's not a 3-month problem. It's a problem which spans over years. So yes, to Andrew's point, you have to trust your team. You have to trust your physician. You have to be comfortable communicating with them. That is absolutely key.
And, does anyone have any advice for patients who are struggling? Andrew, I'm hoping you can kick that question off. I think you are in the position to give the best advice here.
So I realize that this doesn't work for everyone, but my advice is be open. Talk as much as you can to as many people as you can. The more you talk about it, the less scary it gets, the more you learn, and the more people around you understand what you're going through and can help. You see a lot of people who have this idea of, well, I don't want people to worry about me, or I don't want charity, or I don't want, to feel like I'm sick. I just don't. That doesn't work for me. What works for me is talking about it all the time, and no matter how much that frustrates my wife. When I first was diagnosed, we had a blog, and we published this blog so that my wife didn't have to tell the same story and answer the same questions as everybody. And I really think that all your friends want to help. Most of them don't know how. And if you start the conversation, it's going to tell them that it's okay to talk, and it might free them up to asking questions that they might not have asked otherwise.
The importance of community cannot be understated. And I love the advice that, a lot of people do want to help. They just may not know how. Dr. Stevens?
One thing I emphasize with patients is that the targeted therapies are really dosed to toxicity rather than to efficacy. So from trials, we have a starting dose, but that's not going to be the right fit dose for every patient. That's going to balance the effectiveness with the side effects. So I absolutely, like Andrew alluded to, many patients are really hesitant about pausing or dose reducing targeted therapies, but I really encourage them that we have many patients who have good cancer control at lower doses and are able to live a more full life with dose reductions. So that's another reason why it's good to be in communication and collaboration with your team. The other thing, as we've kind of been going on this theme of your relationship with your team, if you feel like you don't have a good relationship with your team or can't get there, the Kidney Cancer Association does have a list of very high volume centers, and also a patient navigator program with one-on-one patient support and support groups that are virtual support groups. So definitely there are resources out there even beyond your cancer institution that can help support you and find the right care.
Oh, good tip. And we will put those links in the show notes so everyone can access those. Dr. Wanchu?
I think whatever has been mentioned, it's pretty much all that I have to say. I do think, communication is key, whether it's family, whether it's friends, whether it's support group, whether it's your own care team. It's absolutely fine to talk about it and not feel as though you're burdening somebody else with your own problems. Sharing really does make it easier, makes it better. And I think that really is key.
Well, I think our discussion today has been really wonderful and very informative. Is there anything else that I haven't asked about that any of you would like to share before we wrap up today?
I'm personally a fan of having an embedded pharmacist on your team. That's always an advantage if you can find it.
And also, I think, this is generally in terms of all patients with cancer. Now with the advent of all these immunotherapies and targeted therapies, a lot of organs do get involved. So it's important to remember that it's not only the oncologist who's going to be managing these adverse effects. You have an onconephrologist, somebody like me. You have an oncocardiologist, oncopulmonologist. So these are people who are specialists, but have also subspecialized in the field of cancer. So, you have that as an additional resource, somebody that you could be referred to if you feel that, your, let's say, kidney numbers are going up on immunotherapy. You could ask your oncologist, well, I think you should refer me to an onconephrologist. So I think that's an additional resource now that, with all these newer drugs and all these adverse effects, we have a large bunch of people who are sort of more focused on this particular, sort of specialty.
I would say, so one thing I would say maybe in closing, these new drugs are new. If this had happened to me 10 years ago, I would be gone. And they're all new. And the slope of advancement in cancer research is almost vertical. It's just amazing what's happening right now. And research in this country is something that is struggling a little bit right now. And call your legislators, ask them to support the NCI and the NIH, ask them to support CDMRP funding for these kind of things. This is really important, and we're not there yet. I'm alive because of these drugs, but it's not a cakewalk, and lots of people aren't going to make it and haven't made it. So we need to continue this development trend.
I couldn't agree more. Definitely get involved where you can. We will also put in the show notes Voices for Kidney Health, which is our own advocacy group, which is made up of great people who really fight to change these policies for everyone. Well, Dr. Wantu, Dr. Stevens, and Andrew, we have run out of time. I really can't thank you enough for joining me today to share this very valuable information. I'd also like to once again thank our sponsor for today's episode, Exelixis. Thank you all for listening, and be sure to check the show notes for resources on kidney cancer, and tune in next time.
Thank you for listening. Do you have any questions? Email us directly with your comments and suggestions at nkfpodcasts@kidney.org. We hope you will join us next time, and from all of us at NKF, we wish you good health.